My name is Rick Lewis. I am a consultant in glaucoma, practicing in Sacramento, California. I've been in practice since 1983, coming out of fellowship at the University of Iowa. And the bulk of my practice is related to glaucoma and glaucoma surgery. I've seen the gamut of problems over the years in terms of diagnosis and treatments, and have an interesting perspective on the introduction of new technology. One of my first publications in a peer-reviewed journal was on trabeculectomy and a prospective study, and we showed then, as I continue to show now, that these short and long-term complications cause significant visual loss and visual morbidity. So it's been my goal all along to get involved in new technology to try to help our patients see better and avoid those complications. In 2002, I was introduced to a company called iScience that was devoted to developing a new surgical therapy for glaucoma. The catheter that was introduced was a 250 micron lumen catheter. It was very lubricious and it would easily pass through the canal. It offered a way to introduce viscoelastic to dilate the canal for that 360 degrees, and then we were able to close off the wound so there wasn't any leakage and no bleb. Later, as we continued to work with the patients, we were satisfied with the pressure reduction, but felt we could even get more pressure lowering by leaving a tensioning suture in the canal. So in about 2006, the concept of passing the catheter plus attaching a proline suture to be left in the canal was formed, and we began to work with it. And that was the origin of the canaloplasty procedure. Over the years, more and more surgeons have caught on to this, along with Dr. Stegman, who innovated the procedure, and many of the surgeons in Germany who were early adopters. We published a series of prospective papers showing that this was a very viable technique, that we were able to get good pressure reduction without the short-term complications of trabeculectomy and without long-term concern about a bleb. It's interesting that having introduced the procedure to this country, although I wasn't the first in the world, certainly Robert Stegman deserves a lot of credit for innovating the surgery, and many of the German surgeons had had greater experience with non-penetrating surgery. I was one of the early adopters, probably the earliest adopter with canaloplasty, and struggled a bit with my colleagues who were very skeptical of the data, of the technology. But we persisted, and I've been proud that its surgery has worked, that it's gained recognition, it's an accepted procedure now. It plays a big role in managing our current problems with glaucoma. I think it's great. You know, I see friends who were skeptical now doing it, recommending it, learning the technology. I see cataract surgeons who avoided glaucoma surgery now doing canaloplasty. It isn't to say there isn't a learning curve with this surgery. Like every procedure, whether it's phacoemulsification or glaucoma surgery, there is a learning curve, but it's more gratifying now because we've avoided so many of those problems we had with conventional glaucoma surgery. I have a very busy surgical practice, and canaloplasty is something that has attracted a lot of patients to my practice. That they read about what we've done, they read our peer-reviewed publications, and tend to be more inclined to come to Sacramento to have me do it. So if anything, it's enhanced my practice. Well, I think the most dramatic example of the benefits of canaloplasty would probably be working with Robert Sinskey. That he who was a pioneer in ophthalmology, pioneered the phacoemulsification procedure and many of the instruments we use, and who is a legend among most ophthalmologists. That when he contacted me to have canaloplasty, that was a sign that we really had come of age, that he had obviously studied the options out there, was well aware of existing therapeutic approaches, and elected to go with canaloplasty and have me do it. It was a big honor. It's been an incredible ride trying to introduce a new technology, a new therapy in this country. That there's a lot of resistance from colleagues, from coding agencies, from insurance companies, and that resistance has been a battle. It's been an education and learning how to deal with it. It's been satisfying that for the most part we have solved all those problems and we've persisted. That this wasn't a flash in the night type of procedure, that we've been able to persevere, and now 10 years into it we have a procedure that is an accepted part of glaucoma surgery.